Tom, I just have to say, I spent the past week reading through your book here, just so you know, and I could show you all the marks and writing I did, circling and underlying and bolding and asking questions in the margins. I just want to say that I've taken, and this was a great, easy read. Just the stories are phenomenal. I felt like I had a full semester course on public health and in personal health. And so I'm excited to share this with our listeners today. If you could, let's just start out with what are some of the key messages, sort of the critical messages you're trying to get across in the book? And I do have specific questions. There are things I really want to dive into, but what are the big ideas here that you're talking about?
Fundamentally, that we have an approach, a formula that has been proven to save millions of lives. It can save millions more, and it could even save your own life because it's relevant for personal health and wellness. And the formula is see, believe, create. And each of those three parts of the formula requires some real attention. So see, to give you the big picture, means seeing the invisible. This is the superpower of public health. And that might be trends in microbes or diseases, but it's also whether programs are succeeding or failing, what toxins or other threats are. Also, seeing why we don't act, seeing why we suffer from what has been called the Cassandra curse. Cassandra, priestess from Greek mythology, was able to see the future, but no one believed her. So when she warned of tragedies that were about to happen, no one stopped and those tragedies happened. So how can we break that Cassandra curse? And the last part of C is seeing the technically rigorous path to progress. But it's not enough to see the invisible. You also have to believe the impossible. There's too often an assumption that the way things are the way they'll always be and the way they've always been. That's not the case. And we can make progress, we can recognize past progress, and we can cultivate optimism to strengthen belief in the possibility of progress. But even seeing the invisible and believing the impossible, those aren't the hard parts of the formula. Those are pretty easy. The really hard part is create. See, believe, create, creating a healthier future. And that requires organization, prioritization, simplification, communication, systematically overcoming barriers, and then figuring out ways to move forward. So see, believe, create is an approach to make our communities healthier, our country healthier, and each of us healthier as well.
Could you, most of us are not epidemiologists or public health officers. And so, we're looking at it from our perspective in terms of, what do I know about epidemics and things like that. Can you give an example of the power of this approach, the power of epidemiology, the power of public health in terms of really saving lives, making a difference? And I'm sure in the book you have many examples. I'm wondering what's sort of a brief example that you could provide us with in the US in particular.
In terms of the power of this formula,
Yes.
well, there are many examples from the US and around the world, from my work and the work of other people. Maybe I'll talk about my work in tuberculosis control.
Mhm.
When I became an Epidemic Intelligence Service officer, or EIS officer, a disease detective at the CDC, I was assigned to the New York City Health Department, and a doctor called up and said, I think drug-resistant tuberculosis is increasing. But because there had been budget cuts at CDC, CDC had stopped tracking drug resistance. So we had no way to know. But New York City has a health code. Health code allowed us to require that laboratories send specimens of the patients who had tuberculosis so we could get them tested in a standard lab. Because resistant testing is actually not so simple to see if TB is resistant. It's gotten better in the years since, but still it's a little challenging. And then it was very challenging and not standardized. So we had it done. And sure enough, this alert clinician was right. TB was spreading, multi-drug resistant TB was spreading. It was the biggest outbreak of multi-drug-resistant tuberculosis the United States has ever had.
What year was
And at
this,
that and
Tom?
at that point, multi-drug-resistant tuberculosis was very difficult to treat,
Uh-huh.
could cost $1 million per patient,
Wow.
and treatment often failed. And I took care of many, many patients, and I oversaw the care of over 1,000 patients with multi-drug-resistant tuberculosis, and very, very difficult. But that led to another mystery, another thing we had to see in the see, believe, create
Mhm.
formula. Why? Where was the TB coming from? The tabloids said it's spreading on the subway, and we didn't know. But we were able to do something even more amazing than check resistance. We were able to take a fingerprint of the bacteria and figure out which strains were connected with other strains. And then we did that classic shoe leather epidemiology work of tracking for hundreds of patients. Where were they that we could track at each moment? In which hospitals, for which days, on which floors? When did they visit the emergency department? When were they in jail? When were they in homeless shelters?
Mhm.
And we could then map the overlap of an infectious patient with someone who was not with TB, but susceptible and later developed TB. And we could see through that that overwhelmingly it was being spread in hospitals.
Wow.
Hospitals were the source of most of the multi-drug resistance.
Interesting.
And with that information, we were able to systematically believe we could make progress and then create a healthier future and decrease multi-drug resistant tuberculosis by more than 90% in just a couple of years. So see, believe, create allowed us to see the problem,
Yeah.
believe we could fix it, and create a future without an epidemic.
The one major difference between every other doctor and a and an epidemiologist or a public health doctor is that every other doctor is concerned with one patient at a time. They're concerned with that individual in front of them, whereas you are interested in everyone. And that is huge. Um, and I have to think, so the story about TB, my first thought is, and again, this is the bias, right? It's like, oh, well, it's those other people who are going to get it, not me or not my family. But when I heard you say the hospital, I'm thinking, oh my God, here's our family members, we end up in hospitals, we end up in EDs at a point when we're vulnerable to infections. And so this isn't some other, this isn't just homeless people or whatever. This is how it affects us, my grandmother in the hospital, etc. But I wonder if you could expound on that because I really think it's a critical difference.
Um, it's important that when we're a clinician, we care about the person in front of us and we provide the best possible care for them. But if you put all the clinicians together, you ask, what's the overall impact of their work?
Mm,
I'll tell you another story about this from New York City tuberculosis days.
mm,
There was a beloved chest or pulmonologist, chest doctor, whose waiting room was always packed. And when asked, what proportion of your patients come back? He said, they all do. Look how busy the waiting room is. And the same doctor who sounded the alarm on multi-drug resistant tuberculosis did a study, and I'll go a little bit more into the background of this study. But what she found was that 89% of his patients had disappeared,
yeah.
either dead or lost. Only 11% were cured.
Wow.
Now, if you hadn't looked at that in a rigorous way, you wouldn't know.
Mm,
You'd think you're doing just fine.
mm,
And that's where we are with hypertension. High blood pressure is the leading cause of death. And we get it right only about 40 to 50% of the time, despite spending $4.5 trillion on healthcare. It would be impossible to spend more money and do worse than we do on the most important things. Now,
yeah.
if you ask any one doctor, they'll say, oh, well, this patient, they were sick, they didn't come in, or, all sorts of excuses. I learned from this remarkable, remarkable physician named Carol Steblow. And what Steblow said was, tuberculosis control is really very simple. There's just one rule: no cheating. you are responsible for every single patient in your area. And if you look at the Kaiser Permanente health system,
Mhm.
they've taken that to heart. And they track every person with high blood pressure, and they have a 90% control rate in their Medicaid population and in their non-Medicaid population among Black and white members of Kaiser Permanente.
Mhm.
So when you talk to other doctors, they'll say, well, these patients don't come back. Well, we know that it's hard to treat hypertension. We know that it's asymptomatic, it's the silent killer. We know that most people don't want to take medicines. All right, so set up a system that makes it work.
Yeah. This is so resonant with me and I think so critically important. I just want to borrow from your book. This is shocking. As much I'm a primary care physician, been doing this for a long time, population health, as well. Uh, Hypertension, as you put in the book, is the deadliest, most neglected, and most widespread pandemic of our time. This is quoting you, Dr. Frieden. It kills hypertension, high blood pressure, kills twice as many people each year as the COVID pandemic did at its worst. And its victims die at a younger age than the people that COVID killed. More than two-thirds of Americans have blood pressure that is not controlled. Two-thirds of Americans. And if you're over 65, 90% of you have high blood pressure that's not controlled. If we don't do something right now, 11 million people die around the globe from hypertension. By 2050, it's going to be over 14 million. I didn't realize I love it that you, as an infectious disease doctor and epidemiologist, are saying the biggest pandemic of our time is not an infection, it's a chronic disease, it's the silent killer. And the the other part that I really, really think we don't have a good handle on in this country. So you talk about Kaiser, but you point out in your book, when you look at Thailand or Costa Rica, how come they have a longer, healthy lifespan? How come they're doing better? And tell me if I got you right here, if I've got this understanding right. The reason is that they're, first of all, they have much more primary care. They invest, many more times, multiple times the amount of money in primary care. But two, I think their primary care is oriented exactly around it's almost a public health primary care, where a doctor has a region, they have a neighborhood, they have a community. And to your point, they are responsible for everyone in that community, outreach to that community, going out. It's not rocket science, but it's a very, very different way of thinking. Rather than my waiting room is full and that's all I care about. It's like, no, there's a community, there's a flock. That's who you have to focus on.
I think one of the great challenges of healthcare is how to have a proactive agenda.
Mm.
Because there's a lot, you're busy, you're dealing with people coming in with all sorts of problems. You've got to separate the serious problems from the things that can be managed easily, the things that require specialist care or maybe hospitalization. So it's very difficult to get past this kind of reactive experience.
Mm.
And I think the only really way to do that is to have a population-based approach. I've thought some about what would a technical package for good primary healthcare look like?
Mm.
And it would have to start with what we pay for. You have to pay for health. You have to identify a population, say you're responsible for that population, and if they're healthier, you'll make more money. And if they have preventable hospitalizations, you're going to have a penalty. I know that's not popular with doctors, but
Mm.
there are some of the ACO projects in the United States, the accountable care organizations that are run by doctors. Those organizations have doubled the income of some primary care physicians, and they've done it by keeping people healthy and out of the hospital. That's a great result. Everybody wins.
Mm.
Primary care doctors are way underpaid relative to other specialists. I looked at this for the book and I was so surprised. I had to have my research assistant triple check it. This is a human research assistant, not an AI research assistant. But Medicare, and you probably know this, but Medicare pays less than 5% of its total payments for primary care. And a primary care doctor who's done wonderful work for 20 years will make less than half as much as a surgeon who graduated yesterday.
Mm.
So when we ask, why do we have a shortage of primary care doctors? Duh.
Mhm. Well, we're not, I agree with you, we're not paying appropriately. And we're
But
not paying enough and we're not paying appropriately, to your
that's
point.
right. That's exactly it. But
Yeah,
payment is just the start of it.
yeah.
You also need to have primary care teams. Teams do better than individuals with nurses, pharmacists, social workers, outreach workers. And you also have to have simple protocols. Um, there's a lot of resistance to protocols, and there's a fascinating history of this with hypertension control, where in the 1970s, there were multiple studies that compared excellent cardiologists with nurse-managed protocol-driven care, and the nurses won every time. So having simple protocols is really important. And you have to make it patient friendly. You have to remove the barriers. I have hypertension, which is really annoying. You know, I do everything right. I still have hypertension. And um, I get my medicines in the mail 3 or 6 months at a time.
Hmm.
I mean, why should I have to go every month somewhere? And we
Yeah.
we work in more than 40 countries around the world. People were being asked to come back every 1 or 2 weeks for medicines, and they should be free because
Hmm.
it's an asymptomatic condition. So the medicines really should be free. Telemedicine is important. We also need to empower the health systems to use data to improve performance because all too often people don't know that they've only got an 11% control rate. And when you know that and you have a work list, you can have the social worker or the nurse or the office manager call and bring people back. You can coordinate. And we really have to focus on outcomes.
Hmm.
Um, we should be able to control not everybody, but much higher proportion. The other thing about high blood pressure is that lower is better down to 120 over 80. And the recommendations are finally catching up with this. I'm not happy if my blood pressure is 123 over 80.
Hmm.
I mean, I would like to see it under 120. Why? Because the epidemiologic evidence is very clear.
Hmm.
It's starting at 115 over 75. For every 20-point increase in blood pressure, the risk of death, heart attack, or stroke before age 70 doubles.
Hmm.
And emerging data makes it pretty clear that high blood pressure increases the risk of dementia. So it is our leading killer. And we have great medicines,
Hmm.
cheap, generic, safe, easy to take, no serious side effects. So we need to do much better.
Yeah. Well, I have to say, I appreciate the argument. It's interesting. I was talking to a colleague and they were at a conference recently, just last week, and someone stood up and said, primary care doesn't pay. There's no ROI in primary care. And my colleague got very upset. But I said, well, did you have the arguments to counter? Because I wouldn't have gotten upset. I would have been like, okay, well, let's look at what there's a lot of science that tells us, in fact, that primary care does pay. And I think, what would you have said to if you were in that conference and got called on to respond to that?
Uh, Primary care pays societally, but as clinicians, it doesn't pay. In fact, this week's New England Journal of Medicine has a series on primary care, the primary care puzzle, it's called.
Hmm.
And they quote Asif Britton, who's a primary care doctor who directs the Ariadne Lab in Boston. And he said, you know, he quotes, this is his quote. You see dozens of patients with hugely varied conditions and stay up nights and weekends. You get phone calls all day long and deal with your 462 messages per week. And meanwhile, you situate yourself at the bottom quintile of your physician classmates in salary, the top in terms of hours worked, and you have a bunch of loans to pay. And within 2 years, you're wondering, am I an idiot?
If I left this conversation and didn't ask this question, I think I wouldn't forgive myself. A lot is happening right now at the CDC, and you led the CDC for many, many years. I think from 2009 until 2017, which seems like that sort of tenure doesn't exist anymore. People are pretty much in and out pretty quickly. What is happening at the CDC from your expert insider point of view? What's happening right now? What's the danger to all of us in what's happening? And what recommendations would you have? And again, I think you're uniquely positioned to answer those questions.
Um, CDC changes are absolutely unprecedented and they're dangerous. CDC exists to protect Americans from threats, whether those threats are infectious or non-infectious, whether they're from the US or anywhere in the world, whether they're man-made or naturally occurring. And what we've seen over the past 11 months is a dismantling of our systems to protect Americans. Um, a quarter of CDC staff have been fired or left. Most of the prior leadership of CDC is gone. The agency is being run by political appointees. They're placed on the CDC website false, unscientific information, completely undermining trust in CDC. So this is a very problematic time. And I think the first thing we have to do is to stop the bleeding. There's still thousands of very dedicated people at CDC trying so hard to do their jobs. And I have no doubt there are people within the administration who want to see a stronger CDC. So we have to stop the bleeding. Second, we have to patch where possible. And that means states, professional societies, universities need to step up with accurate, fact-based, nonpartisan information. And we have to envision the future of public health, which is going to be faster, more connected, better alliances, delivering tangible results, listening carefully to what people are seeing and saying and hearing, and communicating effectively so we can be the entity, we in public health can be the entity that empowers people to have a healthier future.
Mhm. No, that's great. Dr. Frieden, any final comments or thoughts?
The formula for better health, I think, does hold the key for how we can live long, healthy lives and do what we love doing for longer.
That's great. Thank you so much. What a privilege.